Hey eyes and shine my friends, and welcome to the I Give a Damn podcast, made possible by Fluorescene Media, the same company behind Odie's on Facebook. Now, I first want to start off today by first thanking our video sponsor, that of Lens Therapeutics. Now, if you are a doctor who's ever prescribed for presbyopia, then I'm sure you're a master at bifocals and progressives and multifocal contacts and even surgical options for your patients, but you've been probably pretty excited with the development of presbyopia eye drops. Now, I've been digging into the research and reading kind of what's coming out, and it's kind of fascinating because we really only have three miotics. We have pilocarpine, we have carbachol, and now we have aceclidine. And if you're not super familiar with aceclidine, that's okay because it's just coming to US markets. But aceclidine is pretty special because it is a selective miotic, meaning it predominantly affects only the iris sphincter and doesn't activate the ciliary muscle, meaning you can therefore avoid the myopic shift. And again, unlike the other medications in development, aceclidine is the only one to achieve a below 2 millimeter pupil size, which, if you recall from your education as a student maybe, or in your vision science classes, a pupil size below 2 millimeters is really ideal for improving depth of focus. And what I find most fascinating about aceclidine, at least in what Lens Therapeutics has put out in their phase 2 studies, is that it shows a duration of 10 hours with a single administration. That means patients might be able to just put in an eye drop and then reduce their need for reading glasses or anything for 10 hours without having to put more medications or drops in. Either way, I think it's all super fascinating and something that we should all be paying attention to. Otherwise, thank you again to Lens Therapeutics for sponsoring the video. My guest today is Dr. Carolyn Majcher. Dr. Majcher is a strong and experienced educator and well known in the optometry community as an expert in OCT angiography, and Retina. She currently serves as the residency director for the Oklahoma School of Optometry and is a member of the Optometric Retina Society. Today, we get to hear from Dr. Majcher about how she found the profession of optometry and ultimately her career path in academia. We then also hear about her own research in OCT angiography, and she even does a great breakdown of the basics of OCT-A and ultimately utilizing it for a tool for the diagnosis of diabetic retinopathy and macular degeneration. We then talk a little bit more about new upcoming treatments for macular degeneration and her experience practicing in rural optometry. And I'd be lying if I was to say that this wasn't one of my favorite conversations, as Dr. Majcher was, in fact, one of my professors of retina when I was going through my education. And so this was a huge honor for me to reconnect with her and have just an amazing conversation, as she is, in my opinion, one of the brightest minds in optometry today. Now, if you please hit those like, follow, and subscribe buttons and join me in this amazing conversation with Dr. Carolyn Majcher. Dr. Majcher, or Carolyn, which feels...
Please call me Carolyn.
Okay, it still feels really weird for me because I think for every student, when you meet your professor or see them after school, there's still that part of them that lives in your brain that holds them up at such a high pedestal. So it's been really just cool and an honor to have you here and to have this opportunity to talk with you. So thank you.
No, thank you for having me. Such a pleasure.
With for all of our listeners and viewers who are watching today, who maybe have seen you lecture, or maybe you read a publication of yours, or maybe they're like just not super familiar with your background, would you mind just sharing us kind of how you got into optometry, where you went to school, and kind of where you're at now?
Yeah, absolutely. So I went to school at the Pennsylvania College of Optometry at Salus University. I stayed there and did a residency. And then I immediately went down to the Incarnate Word at San Antonio, where I had excellent students such as yourself, where I was there for about 8 years and then transitioned over to the Oklahoma College of Optometry. And I've been there maybe 3 years now as the director of residency programs and an associate professor. So.
And congrats on all of that.
Thank you.
That's amazing. Did you always know that you were going to want to be in academia?
You know, it's so funny. I did not actually, but like I got voted, they have those like awards or whatever, like in your fourth year of optometry school, and I got voted like most likely to stay in academia, and I was like, no way. But then look at where I ended up.
Right.
So apparently they saw something in me I didn't see in myself. So
did you do research as a student? Did you just knew you were going to do a residency sort of thing? And
I just knew I was going to do a residency.
Yeah.
I didn't do any research in optometry school, some in undergrad, but I mean, the residency was so huge in terms of helping me gain confidence in treating advanced disease independently.
Yeah. I know a lot of young ODs, if they're listening to this, maybe they're still students. How did you even decide that you knew you wanted to do a residency? That's an investment. It's a full year, out of your training, potential income throughout your career.
It is. You can do an income-based repayment, which is what I did during that time, but it's really very reasonable, I think. It's just a year. It goes by so fast. You can endure anything for a year, and like all the excellent training I got during that time is like so invaluable. You've never seen somebody who did a residency that said, oh, I regret that. I should have went into private practice and made more money. Never.
Yeah. I know from my experience, when I first went into optometry school, I didn't even know residency existed. I didn't know that was a thing. And so when I first started meeting my professors and realized they all did this extra year of training, and I just knew when I went into school, I wanted to be the best doctor I could be. And I'm like, oh, I guess I'm doing a residency. I got to figure that out. So it is kind of cool to meet all these different doctors of what residency positions they did, and I think more residency positions are opening up throughout the country. But
they are, but there are less applicants. So we really need to promote it as a profession to keep our profession moving forward and strong.
Absolutely. So now, since you finished school and you started teaching, you were involved a little bit in research, and now you're getting pretty involved in kind of the industry side of things too. Can you give us a little bit of insight? Because I've read your CV and you've got all these different publications and things that you've worked on. Can you share us just a little bit of kind of some of your passions that you've worked on and things that you find super interesting in the field of eye care?
Yeah, you bet. I mean, one of my really passion areas or areas of interest is OCT and geography. So I have done some work with that, specifically in glaucoma, where we use like a scleral suction cup to artificially elevate the intraocular pressure.
Whoa.
And then doing OCT and geography to see how quickly there was a decline in perfusion in like the superficial and the deep capillary plexus and in the peripapillary region around the optic nerve head. It was pretty cool.
So what kind of level of pressure are you causing on the eye with these lenses?
We did, I'm trying to remember, I think 22 millimeters above baseline. So, most people around 15 or so. And then we did 30. So, the max was about a 45 pressure.
Yeah, you don't want to be like inducing like permanent damage acutely.
No,
something.
we didn't torture students too bad. But
then again, you're doing it on students too.
Well, this was in San Antonio, yeah.
But I'm just thinking like even during LASIK, when they're doing a femtosecond laser, they're putting a lot of pressure on the eye.
Absolutely.
So
yeah.
I think it's even somewhat realistic to understand how the perfusion pressure is changing even during that procedure. That's kind of an interesting correlation.
Helps you imagine, too, a patient in like acute angle closure crisis where the pressure gets really elevated. I mean, even like 60, 70, neovascular glaucoma, something like that. How easily you can induce a vein occlusion or an artery occlusion just from raising the intraocular pressure. It's impressive.
What's what kind of key takeaways did you guys get from that type of research with OCT-A?
Yeah, similar to other OCT and geography studies, the deep capillary plexus seems to be compromised earlier than the superficial capillary plexus for whatever reason. It's more susceptible to early ischemic changes, and that's been shown in a lot of retinal diseases as well. But there's definitely a correlation between IOP elevation. Like the higher you go, the more reduction in blood flow there is. When you would expect, but it's...
And what about like was there a time factor? I don't know how long you guys held the pressure at that time.
We capped it at 5 minutes to take the scans and then.
And I know somebody asked me that a while ago. How long of ischemia do you have before you start having damage to the retinal structures? Do you have experience in that? Maybe you know more about that than I do.
I think it depends on the clinical scenario. So we know from some of the research that Hayray did on central retinal artery occlusion, it's probably 90 minutes you start losing function. Well, this is in his monkey work. But then at 4 hours, you're pretty much toasted. But I can tell you my experience, we had a patient come through our ER that had a retrobulbar hematoma with a pressure of 60, 70. that he waited, I think maybe 2 or 3 hours before he came in.
Okay.
And that was enough to cause no light perception. Even if we got the pressure down, I mean, he was toasted, unfortunately.
That's sad. With the OCT-A, I know, like our clinic, we have an OCT-A, and we've been using it for a few years, and I've got a couple of books
awesome.
and things that I've read on it, just so I'm a little bit more prepared with analyzing it, reading it. But I know a lot of doctors, it's still a new thing, and we're still learning a lot more with publications of how to use it. Can you give us kind of, for any doctors who's listening in and maybe knows kind of what it is, but maybe not super familiar, maybe they don't have access to it yet, can you give us a little kind of just a fundamental breakdown of how it works and kind of what you use it most for?
Yeah, you bet. I mean, I think the downside is there's a pretty steep learning curve to OCT and geography, but like just the basics of it, it's very similar to your regular OCT imaging. It's just you're doing it like 4 times consecutively, and any changes detected would then be considered red blood cell motion. So you're basically capturing a snapshot of red blood cell motion at the time the scan is taken, rather than, say, with fluorescene angiography, where you're watching dye travel through the vessels over time. Mm-hmm. And for that reason, you get really high detailed resolution images that are also volumetric. So you can segment out and say, oh, I only want to see preretinal neovascularization, or I only want to see choroidal neovascularization, which makes it very valuable in that way.
And I think that's the few times I've probably found it most valuable, is certainly in those cases of any sort of retinal lesion or vascular changes, right? Because it's looking at more of those, the blood flow component.
It is like a workhorse, I think, for diabetic retinopathy and macular degeneration.
For diabetic specifically, are you looking more at foveovascular zone? What kind of gives you a tip-off?
The foveovascular zone is useful in the sense of detecting macular ischemia. Mm-hmm. So you might have a patient with diabetic retinopathy that has reduced vision but doesn't have macular edema, but then you see that their foveovascular zone is enlarged, it's irregular contour, and you can kind of explain it in that way. But I find myself using it more so to detect early proliferative diabetic retinopathy, like teeny tiny preretinal neo that otherwise I would have looked at and said, oh, maybe that's IRMA, or I just didn't even see it all clinically.
And that's, I don't know, I'm just blown away by looking at the images, because, you know, we see so much clinically behind the slit lamp, and we're like, gosh, we can see all this. But then you look at that angiography and you're like, oh, I don't see a tenth of what this imaging is showing, because it's just so detailed.
Oh yeah, some of that high resolution imaging, like seeing IRMA, is so much more prominent on OCT angiography than, say, like color fundus photography or ophthalmoscopy. Also, like retinal non-perfusion, right? If you think about it, like acutely, retinal non-perfusion looks sort of like a cotton wool spot, right? It's kind of like white, fluffy, thickened area of the fundus. But then over time, that appearance goes away, but that there's a permanent footprint of retinal non-perfusion that remains on OCT angiography always. And so you'd be surprised sometimes when you image a patient with montage OCT angiography and you're getting outside the arcades how much non-perfusion is present that you were missing with your clinical exam.
Gosh, I can't imagine as OCT and imaging starts getting better and better, what it'd be like to get a complete OCT of even the peripheral retina. That would be...
It's out there, it's just not in the US quite yet. Like in the US, we're getting probably max like 14 by 14 millimeters, which is like my montage that I can get on my instrument, but it still gives me so much value. And a lot of the neo's not in the macula, right? If you do like a 3 millimeter, 6 millimeter scan of the macula, you're gonna miss the neo. You have to do the montage looking in the arcades, and that's where you're gonna see it. And my retina specialists, they will do PRP at the first sign of proliferative.
Okay. And are your retina specialists using the OCT-A, or are they mainly focusing on like fluorescene angiography?
Mainly fluorescene angiography.
Yeah. So, I mean, has there been a case where you've maybe caught like early proliferative or something changing with fluorescene angiography, and then send it to your retina specialist, and they're like, nope, there's nothing there, because they're using like FA or something? Have you ever had that?
Oh, do you mean like I caught something with OCT angiography and then referred it?
Yeah.
Oh, yes, absolutely. Actually, I have a case of like obvious disc neo, and I even feel like on the color fundus photograph you can see it, but it's very obvious on OCT angiography. Referred it, he's like, oh no, it's severe non-proliferative, see it back in 6 months. At that 6 month follow-up, he said, oh yeah, it's proliferative, and then he did PRP. But the patient's still 20/20, I mean, so it worked out. Yeah. But yeah, I mean, I think it can really highlight some of the early neovascular vessels that maybe are a little bit more substantial, and they're not leaking on fluorescene angiography, so they they're missing it on that modality.
There's so much with OCT-A, and again with ours, like I've got a couple of books on it, so I had to kind of teach myself because it's not something I learned when I was in school back in like 2015. We didn't really have it.
It had just been coming out.
Yeah. So in your, I know we don't have like an OCT-A image right here, but just off the top of your head, can you just tell us like the fundamentals of what you look for, or maybe what you'd teach one of your students in school right now? Like, what's the first thing they should look at, and how do they kind of work through it?
Yeah, you bet. So every like brand of OCT angiography has its own like preset NFOS displays, and it's usually the NFOS display that I'm looking at the most for retinal disease. And the superficial deep capillary plexus is derived from the central retinal artery, so that's where you want to look if you have a patient with diabetic retinopathy, retinal venous occlusive disease, whatever that may be. And then on my model, I have it's called a VRI, vitreoretinal interface. Some of them call it vitreous, depending on the model of OCT you have, but that's to look specifically for pre-retinal neo.
Okay.
So if it's inner retinal disease, you want to be looking at those, and then if it's outer retinal disease, again, it goes by a lot of different names, but like avascular, outer retina choriocapillaris, that's where you want to be looking for choroidal neovascularization or choroidal non-perfusion.
Which makes sense, just based on our knowledge of what those diseases, the pathogenesis is. And for our viewers who are watching this on YouTube, I'll put a little slide in there so people can see which layers you're talking about through that. I know with just one case that I've had in the last few years, that OCT-A, like I can think of one where it's like that made the diagnosis for me. Do you have any? I can share mine, but I'd love to just hear if you have any specific cases that you're just like, this made the difference in your diagnosis management.
I think of at least three very like powerful examples. Like the first being early detection of proliferative diabetic retinopathy. I've had at least 10 patients where I didn't see it clinically, I would have missed it otherwise. And probably more to come, surely. Yeah. But then macular telangiectasia type 2 is actually like really subtle in the early phases. Even on structural OCT, like there may be just a little bit of photoreceptor loss on the temporal aspect of the macula, or there's like reduced vision and you can't really explain it. And then you do OCT angiography and it really highlights those abnormal telangiectatic vessels, particularly in the temporal aspect of the macula. So I think that's another huge takeaway for OCT angiography. And then lastly, macular degeneration. It's huge, right? Because with OCT angiography, you're directly visualizing the membrane, right? Versus just structural OCT, you're looking at the secondary effects of the membrane if it's exudative, right? So like fluid, blood, whatever. But if it's just a membrane that's non-exudative, like a quiescent CNV, the only way to look at that directly is with OCT angiography, right? Like we won't see it on fluorescene angiography. And on structural OCT, there may be some clues if you have like a low-lying pigment epithelial detachment or something. But then OCT angiography is going to tell you that that's there. And we know that that lesion, non-exudative choroidal neovascularization, is a high risk to convert to exudative AMD that would require anti-VEGF therapy in the future.
So at least maybe that would tip you off, okay, let's get you referred to the retina specialist right now just to kind of get that, or maybe manage them sooner, follow them up sooner?
I personally will hold on to that because I feel comfortable and I have the technology to monitor a patient like that. Like my retina specialists, they will not inject until there's exudative features, if there's fluid, if there's blood. If it's literally just the membrane with no fluid or anything around it, we're just going to watch it until it becomes exudative and then inject. So I'll monitor that usually on a 3-month basis, but make sure that the patient is very vigilantly monitoring themselves at home. And I think that's a great application of, say, like the Nodal Vision for C Home device, where they can closely monitor their vision at home, or Amsler grid, whatever, but trying to be really vigilant on their end as well to catch the earliest conversion to exudation that would be treatable.
No, I know it's a little, you brought it up. What's this at-home kind of vision monitoring for? I know they've had, I've seen some pictures of devices, but I personally have no familiarity. I've never prescribed one for my patient. Don't even know how to get one for my patient. Can you? It sounds like you at least.
Oh, absolutely. Nodal Vision makes a device that's called the Fluorescene Home, and the intent of the device is to sort of be better than the Amsler grid, where you're trying to catch conversion from non-exudative to exudative AMD. So its greatest application, and it is prescription only, so it would be prescribed in intermediate stage AMD, where you know there's a substantial risk that a patient could become exudative in the future. It's a like hyper acuity type of perimeter. So the patient does it one eye at a time. They come install the device in the patient's home, and the intent is that they do it daily. And it's like a line with like a little bump or wave in it, and they would click with a mouse like where they see the little bump, and it will determine the baseline for the patient as well as compare it to a normative database. Okay. And anytime it changes in the future, it will alert the prescribing doctor so that they can bring the patient in for an exam.
What? So you've prescribed this for your patients, or have you guys used it?
Unfortunately, I have not, because I'm in the like Indian health system,
Sure.
And we don't have funding for it right now. But it is covered by like Medicare if you have certain diagnoses and if you have secondary payers. It may be very cheap for a patient to do it, actually.
I'll have to do some like investigating into kind of maybe if I can get that, what kind of access I can get for my own patients and that. So
yeah, but if I was in private practice, I'd be using it tomorrow. Like it's just like right now I have barriers to getting me there because the data is so strong in terms of like when patients convert. I think the mean acuity or something was like 20/40, and they were to maintain that. Can you imagine like having exudative AMD, being treated with anti-VEGF, and you're maintaining 20/40 vision? It's like incredible.
Yeah, instead of being 2200 or something like that. It's that because that 20/40 vision is still, at least in Minnesota where I practice, that's still driving. That versus somebody who's like, I can't see my family, I can't read, I can't function. It changes your life. Hey, I just want to take a quick moment to kind of call out a disclaimer that we're about to shift into discussing some of the new medications for geographic atrophy. And with this, we also discuss potential complications and published potential side effects from this medication. But since this initial recording interview with Dr. Majcher, some new publications have come out. And I just want to kind of give that disclaimer that we don't kind of encompass all what we know at this exact given moment. So if this is something that particularly interests you, please do your due diligence and reading new published research regarding any potential side effects, use, or complications of these medications. Otherwise, let's get back into the conversation. Being that we're talking about macular degeneration a little bit, I know we've had a lot of new changes with geographic atrophy in the last, just with kind of this, even just the new, I find fascinating is just the research, what direction it's going, right? But tell us, if you mind, I think a few other guests I've had previously, we kind of touched on it, but we never went too deep into it. But what's kind of your familiarity with the new it's not an anti-VEGF, but it's still an injection.
Complement inhibitor injection. Yeah, intravitreal injection, you bet. So there was one just FDA approved in February, Savovry, through Apellis Pharmaceuticals. And then Iveric Bio is also working on one that they expect to be FDA approved in August, so very shortly here. So I think that we'll have two sort of competitor medications on the market here shortly. But both of them are complement inhibitors, so they target inflammation, essentially. And the thought is that they can slow down the growth of geographic atrophy. By no means does it bring vision back, and by no means does it halt the disease process where it is, right? It's very similar to glaucoma, where you're still going to progress, you're still going to lose vision, but we're trying to slow it down. And I think particularly beneficial in extrafoveal GA, right, where they still have good vision left, like 20/20. It's so bad. I think of it sort of like a cancer diagnosis, where it's like, well, we give you 6 months to live, but we can give you this treatment and give you 12 months or something. Like, we're going to be able to extend the time of how long it is until the GA invades the center of the fovea, at which point the vision usually plummets, to 2200 or something. But we're able to give them a few more years of reasonable vision. Yeah,
because as soon as you start barely seeing signs of GA at all, not even in the fovea, you're like, within 5 years, there's a good chance it's going to spread to that point. So, it's I think it's frustrating a little bit because we want like a cure, and it's not really a cure.
I wish, right?
But you can imagine if I was presented, not just in your 80s, but like if I was there's people who develop AMD in their 50s. And you think, I'm going to retire. Well, you may not be able to see in your retirement. So this is at least a great beginning point for us to get more research and find out more, because maybe down the road we'll have something more too.
Agreed. And I mean, this is, like you said, I think just to start. Like, I'm excited to just have anything. Like, do I wish it was better? Yeah, but anything is better than nothing, I think, at this point. But I think the education from from an optometrist and retina specialist side to the patient is going to be really important. Like they have to be willing to undergo intravitreal injections, and it's looking like it's similar to glaucoma, like where once you put a patient on medication, it's like a lifelong sort of thing, right?
Yeah.
Or until the vision declines so bad that you just would stop at that point. But they have to be willing to undergo that burden of treatment, which is a burden, truly.
Yeah, because right now I think based on the studies for the approval, it's every month.
It was, yes, monthly or bi-monthly, so every 2
bi-monthly.
months. I think most retina specialists that have adopted it are doing it like every 6 weeks, but it's going to depend on the specialist. But yeah, I mean, that's a burden, especially if you, so I mean, I practice in a really rural area right now, like Tahlequah, Oklahoma. Like my patients to see a retina specialist have to drive like an hour, 15 minutes, or they have to get a ride. You know what I mean? It's significant.
And then wait 3 hours to actually get in to see the specialist. That's at least the experience a lot of my patients come in. You know, they're like, I went to this and the room is just packed with like 80 people, and then they wait for 3 hours just to see the retina specialist to get 5 minutes with them.
Yeah,
you know?
right.
And then their eyes hurt for the next few days. You know, that's kind of the story I get.
But I've had some patients who are really motivated and like gung-ho. They're like, I've been seeing my vision decline and I really want to keep what I can, you know, while I'm still living. And they want to go forward with it, like willing to do it bilaterally. I mean, if you have a patient that's already exudative in one eye, right, and is getting anti-VEGF for that eye, and then you have GA in the fellow eye, you could just do injections on the same day of 2 different medications.
Sure.
You know what I mean? So there's some scenarios where I think it's going to be more convenient for the patient, especially if they are already familiar with what an intravitreal injection is like. Or if they have central GA in one eye, so they know what it's like to lose vision, and then the fellow eye has like extrafoveal GA, you'd be highly motivated to treat that eye.
Absolutely. I know it's, as far as just, are your retina specialists already prescribing it then, or do you have experience with that referral?
The rollout has been slow, and I think it's a billing and coding, like getting paid for it issue at the moment. Like they did do some sampling in our area. Like I have one retina specialist I refer to who's like really gung-ho about it on top of it. I have another one I reached out to, and he's like, we're just going to kind of watch and wait and see what happens. Because I think, you know, there were some issues with past medications where they were surprised by complications, and they didn't just tread lightly and be a little bit more cautious.
Are there any complications really at this moment other than just complications from having an intravitreal injection?
Yes. So in the phase 3 clinical trials for Savovry, or that got it FDA approved, which was the Oaks and Derby studies, there was like a dose-dependent increase in the incidence of choroidal neovascularization, believe it or not, which is kind of interesting, right? So I guess if you imagine you're keeping alive like sick RPE, that's probably releasing more VEGF, whereas if you weren't treating, it would have just died off. You know what I mean?
I have to wrap my head around thinking of it that way a little bit. Because it's basically dying slowly or starving in a way, and so it's releasing more VEGF.
Yes, but we have very good treatment options for choroidal neo nowadays. So like in the clinical trials, I believe when a patient converted to exudative AMD, they just did, on different days, of course, like injections of complement inhibitor as well as anti-VEGF on another day. They just get both.
I'm curious, just because again you're working in Oklahoma, and a lot of your patients are from like an Indian Reserve or Native American sort of position. I haven't had much experience working with that population. Do they have a higher amount of macular degeneration? Does that run more in that?
We actually see a good amount in a lot of glaucoma and diabetic retinopathy.
Okay.
I mean, I love like rural optometry is the best actually, and what has been so. I learned so much from the ER experience there. Like we have one ophthalmologist at the school who's unfortunately leaving. So there's no ophthalmology in Tahlequah in that area. So we are like the primary eye care for everything. So like our residents are on call all the time through the ER. And as the residency director, I'm kind of like the first line of backup. So like we just saw a really cool case of like Percher's retinopathy, like stuff I would have never thought I would see, you know, and I've learned so much. Like the learning curve there has been really steep, but it's been good. So
I think when I did my residency, I know they said you're going to get really comfortable with being uncomfortable. It's fascinating how much you learn in school, and you do read these small minutiae of things, and then you think, oh, I'll never see this weird infection that's only in East Asia or whatnot, and then sure enough, you're like, what is going on in this person's eye? And then you start reading through the books again, and you're like, this seems familiar, but I don't know what it is. And then sure enough, or you refer it and you get the thing back and it's like, oh my gosh, that is that disease.
Yeah, right, yeah.
So I know a kind of what I mentioned earlier with OCT-A, I've had acute macular neuroretinopathy.
Oh, how cool.
It's, I looked it up. It's like supposed to be super rare. It's like 1 in a million cases. I've had 2, if not 3 now.
Oh, how interesting.
Within the last few years, but it's all related to COVID.
Oh.
But I only got, and I looked it up, there's other case reports on this, and it's all in females within 1 to 2 weeks of getting COVID, and they have scotomas in their vision, and they come in to see us. And I remember the first time we had it, I was working with a student, the student worked up the patient, and fundoscopically I could see these small, like wedge-shaped lesions around the macula. But when we took a fundus photo, it didn't really show up. It was kind of a unique fascination of like, why can I see this? I don't know if it's because of binocular view versus a monocular view with the camera. But then I had the student run the OCT-A and come back, and they're like, nothing's on there. And I look at it, and I instantly see in the en face, I'm like, those are those lesions I could see. I could see in the en face. And then once we were able to like kind of pinpoint where those lesions were, I could look at a deeper side of the photoreceptors of the outer plexiform layer and see thinning and be able to kind of correlate and finally make a diagnosis and follow those patients over time. So
Well, you bring up a great point. Like, just structural NFOS is really underutilized, but it's very valuable for a situation like that you're describing, where there's like this geographic or whatever pattern of photoreceptor loss. You can capture that very nicely with NFOS, structural OCT.
Yeah, NFOS. Sorry, ONFOS, NFOS. I'm not sure how to pronounce
that.
It's like all the medications, the new geographic atrophy medication. I'm like, I don't know how to say this. I'm just gonna.
I just say ACP or something.
I don't know. I'm gonna spell it out phonetically and just hope that's right.
Yeah.
There's people who argue prostaglandin analogs versus latanoprost versus latanoprost.
Oh yeah.
little pronunciation changes. Well, Dr. Majcher Carolyn, thank you again for being here. This has been an honor for me. So.
I had so much fun too.
Yeah, thank you, and I'm sure we'll hear from you again coming up soon. But otherwise, hope you have a fantastic rest of your meeting here, and we'll talk to you soon.
Thank you.
So that was our conversation for today. Thank you so much for joining us. If you are enjoying this type of content, please do yourself a favor and follow us either on your favorite streaming service or subscribe to our channel over on YouTube, because that will go ahead and remind you whenever our next episode is coming out. And if you're somebody who is finding a lot of value in this content and also gives a damn about your profession of optometry, then please do us a solid favor by leaving us a review on whatever streaming service you are using. That will greatly help us out and help more professionals find this content. Otherwise, again, thank you for listening in, and I hope you have a fantastic day. We'll see you soon.